So today I'll be talking about degenerative cervical myelopathy. So just a bit of an outline. I'll be going through some of the background, the relevant anatomy, pathophysiology, what to look for on history, examination and investigations, classification and management of the condition. So degenerative cervical myelopathy is a broad term. It describes the various age-related degenerative conditions of the cervical spine that result in neurological injury to the spinal cord through both static and dynamic injury mechanisms. It was classically referred to as cervical spondylotic myelopathy. However, in the last few years, the term DCM has been used instead, as it amalgamates a number of related conditions together for ease of description in the literature. It's the most common cause of spinal cord injury in developed countries, with an incidence of approximately 6 per million in Australia and 76 per million in North America. However, the true rates are probably a bit higher than this, as it's a bit of an underdiagnosed condition. There is an increasing prevalence with the aging population and some better recognition of some of the signs and symptoms. So just to briefly go through some of the relevant anatomy. So on the left here, we've got an axial transection of the cervical spine. Moving from anterior to posterior, we've got the anterior longitudinal ligament, which isn't labelled on this left-hand image. Posterior to that, you've got the intervertebral disc or the vertebral body, depending on the level that you're at. Posterior to that, you've got the posterior longitudinal ligament, followed by the spinal canal itself with the facet joints on either side, the spinal cord, and then along the border of the lamina and the spinal canal, you've got your ligamentum flavum, and we've got a sagittal cross-section here demonstrating that as well. So the anterior and posterior longitudinal ligaments followed by the spinal canal and then the ligamentum flavum. So these structures are all relevant because they relate to the sites of compression of the spinal cord. So anteriorly, with age, we get disc desiccation and bulging and uncovertebral osteophytes. Posteriorly, you get your hypertrophied ligamentum flavum and degenerative facet joints, all of which can contribute to compression of the spinal cord. It's important to note that pre-existing narrowing or congenital stenosis may predispose to myelopathy. So we're talking about a spinal canal approximately 12 to 13 millimeters. So in terms of the pathophysiology, it can be broken down into static and dynamic factors and also the effects on how it looks histologically. So with regards to static factors, we have disc collapse and posterior bulge, which causes narrowing, and shortening of the spinal column from the shortened disc alters the biomechanics. We also get ligamentum flavum thickening and ossification of the posterior longitudinal ligament. Reduced movement at these levels then causes hypermobility at the adjacent spinal levels. We also have dynamic factors, so abnormal repetitive movements during flexion and extension cause compression. So for instance, in flexion, compression against the anterior osteophytes and discs occurs, whereas with hyperextension, the cord can get pinched between the posterior margin of the vertebral body and the buckled or thickened ligamentum flavum. And under the microscope, this results in this process of mechanical compression causes vascular changes, leading to ischemia and inflammation. Over time, this leads to neuronal cell loss and degeneration, which we see as functional decline in the patient. This is a good diagram which illustrates some of the changes we can see in myelopathy. So more superiorly, we can see some of the normal anatomy, and then we can see here an example of hypertrophy of the ligamentum flavum posteriorly, some osteophyte formation in the vertebral body with some loss of disc height, or with some loss of vertebral body height. You also have pure herniation of the intervertebral disc with herniation into the canal, hypertrophy and ossification of the posterior longitudinal ligament. And all of these factors combine to cause compression of the spinal cord, as we can see there. So when assessing a patient in myelopathy, it's important to take a very thorough history. Paresthesia in one or more extremities is one of the early signs that you can elicit. Clumsiness is often how the patient will describe the fine motor changes that they develop in myelopathy. So they may have difficulty with buttons and getting dressed, handwriting. Upper limb radicular pain is a very common sign in up to 86% of patients. Neck pain a bit less so in about 60% of patients. A lot of patients will describe gait disturbance or generalized weakness. So they may describe this as now needing to use a gait aid, whereas previously they were walking independently, or needing to use a handrail when using the stairs. Bowel and bladder dysfunction is less common, and it's more an indication of more severe disease. I think it's important to note that you won't necessarily get all of these symptoms. Some patients may present with just one or two, which is one of the factors I think makes it more of a difficult diagnosis, and one might maybe a bit underdiagnosed. But if you've got a patient who's got some declining mobility or function, it's always worth having as a differential. So the examination findings, a lot of them revolve around typical upper motor neuron lesion signs. So patient will have weakness, often relating to the intrinsic hand muscles, hyperactive reflexes, clonus in the patella or ankle, an inverted brachioradial reflex, positive Babinski, so an upgoing plantar reflex, positive Hoffman sign. So this involves flexing the distal interphalangeal joint of the middle or ring finger, which will then activate the long flexors, causing flexion of the thumb and the index finger, as demonstrated in the photo on the right. Romberg sign, so getting the patient to stand up with their eyes closed, feet close together and arms extended, and a loss of balance. So a positive sign there is sometimes an indication of myelopathy. And then neck movement as a trigger for pain can also be a sign. In terms of investigations, it's important to start with an X-ray. This tells you a number of things. So the C-spine alignment, seeing if the normal lordotic alignment is maintained, or if they're in neutral or have gone into kyphosis. Assessment of the disc height, end plate sclerosis, and the presence of osteophytes. MRI remains the gold standard for confirming the diagnosis. It allows visualization of the spinal cord, nerve roots, and CSF. The T2 weighted images are especially useful as they help you assess for cord signal change, which shows up as myelomalacia on the MRI. CT myelogram may be an alternative in patients who cannot have MRI for various reasons, for instance, a non-compatible pacemaker. However, it is an invasive investigation, and it's not as useful compared to an MRI. There may be a role for EMG if you need to exclude other diagnoses, such as neurological conditions like motor neuron disease or multiple sclerosis. So there are a number of classification systems. However, the one that's quoted most in the literature is the modified Japanese Orthopedic Association scale. So this is an 18-point scale that looks at motor function in the upper and lower extremities, sensory changes, and bladder function. And it ranges from 0 being an inability to have any motor function, a complete loss of sensation, or inability to empty the bladder voluntarily, up to 5, 7, 3, and 3 if there's normal function. So it's an 18-point scale, and a lower score indicates more severe disease. So patients can be divided into mild, moderate, or severe, depending on their score. So the management, we can divide into non-surgical and surgical management. Non-surgical management really is only in patients with mild disease without functional impairment and who maybe have some other comorbidities that might make surgery higher risk. In these patients, options include physiotherapy to help with gait training, occupational therapy to work on upper limb dexterity, neck immobilization, usually in a hard collar, activity modification, so avoiding things like contact sports, which may increase the forces going through the C-spine. And it's important to monitor these patients closely as they're at risk of deteriorating clinically. Our surgical options, we've got operations from both the anterior and posterior approach or combined approaches. So from an anterior approach, an anterior cervical discectomy and fusion, or an anterior cervical corpectomy. Posteriorly, we can do a laminectomy with or without fusion, or a laminoplasty. The considerations in terms of which approach is used depend on the number of levels involved, the sagittal alignment of the C-spine, what existing motion there is in the C-spine and what we're looking to preserve, and the comorbidities of the patient. So looking a bit more closely at surgery specifically, the goal is to decompress the spinal cord, stabilize the spinal column, and prevent further neurological damage. It is important to note that there have been multiple studies which demonstrate that you can actually get an improvement in neurological function as measured on the Modified Japanese Orthopedic Association scale, with an average improvement of 2 to 3 points after surgery. The patients which are more likely to improve are those that are younger, those that have milder symptoms, that have a shorter duration of symptoms preoperatively, non-smokers, and patients without any gait disturbance. With regards to which approach should be used in terms of anterior versus posterior or combined approach, there are multiple studies which have demonstrated no significant differences in the neurological outcome. The approach should be dictated by the location of the pathoanatomy and the factors involved in the patient. So, with regards to an anterior approach, this should be considered strongly when there's anterior cord compression and when there's significant kyphosis of more than 13 degrees. These patients are at higher risk of hematoma, a hoarse voice, and dysphagia. A posterior approach is that this should be considered when there's posterior cord compression, there's a history of congenital stenosis, there's multiple levels involved, usually more than 2 levels, or there's ossification of the posterior longitudinal ligament, which would make an anterior approach less suitable. These patients have been found to have greater length of stays in hospital, high risk of wound complication, and high risk of medical complications. The combined approach, you'd be looking to use this more in patients that have multi-level disease and also have those who have a kyphotic deformity at the same time. So just looking at anterior cervical discectomy and fusion, or ACDF, more closely, this is the mainstay of treatment in patients with single or 2-level disease. It uses the interval between the sternocleidomastoid and the strap muscles and largely involves blunt dissection. The pathological disc is removed. The posterior longitudinal ligament, which is causing compression, is also removed at the level of the compression. A foraminotomy can be done if there's nerve root impingement at the same time, and then a fusion is carried out, usually with the use of a cage with bone graft and a plate anteriorly on the vertebral bodies. This surgery allows for correction of kyphosis, which is why it's one of the preferred operations in patients with a kyphotic deformity. It does have a lower infection rate, less blood loss, and less post-op pain, and it allows direct decompression of the spinal cord at the relevant level. Things we have to warn patients about, particularly with this approach, there is a risk of the myelopathy worsening still, a risk of infection and hematoma, dysphagia, as the esophagus is often needing to be retracted quite forcefully out of the way. There is a small risk of esophageal perforation as well, and also hoarse voice as the recurrent laryngeal nerve passes through the surgical field. So in summary, degenerative cervical myelopathy is the most common cause of spinal cord injury in developed countries, with likely an increasing prevalence with the ageing population. It's mainly a clinical diagnosis with MRI confirming the levels involved. The modified Japanese Orthopedic Association scale can be used to help classify the severity. Surgery aims to arrest neurological deterioration and should be considered in most cases, and the approach should be tailored to the individual based on their deformity and sites of compression, as there's no difference in neurological outcome based on approach alone. Thank you.